My name is Dr. Matthew Lynch. I work out of East Windsor, New Jersey. I'm a plastic and reconstructive surgeon. So breast reconstruction covers a lot, and it just depends on what the patient really requires and needs. And so here we try to evaluate the patient to understand what their expectations are and what they really want out of the whole process. And so we don't necessarily have a cookie cutter type approach to one or any patient. It's kind of finding out who they are and what makes them tick, and then kind of figuring out what is the best process for them. And so we'll spend a lot of time with each patient, probably over an hour initially, just to find out what their disease is like, what kind of treatments they're going to require, and then at the end of the day, what their expectations are from the procedure and the whole transition of the treatment. Typically, we look at it from simplest to more complex, and so it can be anywhere from just a simple closure to making the chest wall as flat as possible so the patient can be comfortable. And depending on what the patient's body habitus is and what they are, again, expecting from the reconstruction, it can be an implant-based reconstruction with or without a tissue expander. It can be an autologous-based reconstruction with a deep flap, or a tram flap-based reconstruction from the abdomen, or a back surgery, which is latissimus dorsi flap with typically an implant. They're the main ones. Again, it really comes down to, number one, what their expectations are, number two, what their treatments will be, and number three, what their body habitus is like, or what other treatments or scars they've had in the past. And so we try to go through that process to kind of figure out which one fits them the best. And then once we determine that, then we try to make it happen for them. I would say the majority of patients these days are having prepectoral-based reconstructions with the use of some type of allograft to help with some of the camouflage of the implant. Subpectoral we reserve for patients that are very thin, have limited soft tissue coverage, and sometimes we'll use that. Again, a tissue expander is used if the tissue is not optimal or the healing may be in question, and then we will go to a tissue expander so that it gives us a best chance for healing. So typically, patients in my practice will have either a unilateral, bilateral tissue expander or an implant or direct implant-based reconstruction. Typically, those patients, again, are prepectoral, and most of the patients are going home the same day. We'd like to see the patients on post-op day one in the office just to make sure that they're healing okay, their drains are in the correct position, their bras being worn correctly. We're big believers in that if you let something fester for a while, it'll cause more problems. So the more we see the patients initially, the better chance that we're going to pick up something that could be reversible. And then typically patients recover relatively fast. It's not a terribly painful procedure. We don't want them to use their arms extensively initially, just because we want to keep the motion down so the drainage is limited, so we can get the drains out as soon as possible. You know, the drains can be a source of infection, and so the longer they stay in, potential risk for infection goes up. And so once the drains are out, then we send them to physical therapy to get the motion to where it should be. So long term, you know, we typically see the patients annually just to make sure that they're doing okay, make sure that we can supply them with any knowledge of any new technologies that are out there or new treatments so that we can improve upon their reconstruction, and just to check on them and stay in contact. You know, typically I would say most people will put a 10-year warranty on most of these implants. 10 years, if everything's perfect, then we would continue to follow you. If there is something wrong before that or at that time, then we make suggestions on how we could revise it or make it better. So with the beauty of plastic surgery, we're always innovating and we're always trying to find better ways to do things, and so things do change relatively fast. And so again, I'd like to just try to be in contact with my patients so that we can give them the opportunity to have the best reconstruction possible.